Thank you. Danielle, it's a pleasure to be here with you, and I thank you all for attending this session. At University of Miami, I'm actually an MIS surgeon, but one of my biggest practices is also flexible endoscopy. And obviously, as in the SAGES meetings, one of the things we promote the most is surgeons continue to promote endoscopy. And as a surgeon who's been doing endoscopy for many years, I look at the session, and often we say, yeah, we know everything there is to know about Barrett's, and I realize, just looking through some of these decks, slides, there's a lot that I'm going to learn, and hopefully it's the same thing you guys are going to learn, some of the things to take away from these talks, from the basic science to diagnosis, treatment, and very advanced therapies. So it's a very pleasure, and I think you're going to find it very valuable. A couple of things also differently, the evaluations, please continue to give us all the feedback, positive, negative, whatever it is. But it's obviously important for us to continue to figure out what we want to do in the upcoming sessions and years. Also, at the end of this session, the exhibit hall will be open in Exhibit C, so we also welcome you to come on by there and see the exhibitions that's going on. With no further ado, we're going to continue with our first speaker, Dr. Daniel O. Dr. Daniel O is one of our thoracic surgeon speakers. He's an assistant professor of surgery at USC in California. So thank you very much for joining us.
Thank you to the SAGES Committee for the privilege to present on this topic. I have no disclosures relevant to this presentation. Gastroesophageal reflux disease remains the #1 GI-related health problem in this country. The burden on our socioeconomic capacity is significant, with over $12 billion in direct costs. Despite billions of dollars every year spent on acid suppression therapy, we are failing. The incidence of esophageal adenocarcinoma continues to climb. This is the latest SEER data. You can see on that red curve here that the incidence of esophageal adenocarcinoma is not plateauing. The critical piece seems to be Barrett's esophagus. We are not finding enough Barrett's esophagus to explain or to make an impact on the outcomes of esophageal cancer. We know that people with Barrett's have a higher risk for cancer. We know that if we catch them as they progress to dysplasia, we can ablate the dysplasia and prevent cancer. We also know that Barrett's surveillance detected cancers are found earlier than patients who present with symptoms, and oftentimes we can treat this with endotherapy with superior outcomes. The prevalence of Barrett's esophagus is very variable, 5 to 15% in high-risk individuals. This is in patients who have chronic reflux symptoms. It's estimated about 1 to 5% of the total population has Barrett's. But it's highly variable depending on the publications you look at. It can range from 0.9% all the way up to 25%. So it's the difficulty in defining Barrett's and therefore detecting it and following it is that there are several factors that go into it. #1, there's still a lot of debate on how we define Barrett's. Most recently, the biggest controversy is what to do about biopsies. Should we mandate the need for intestinal metaplasia or not? The other area of controversy is the length of the columnar segment. Historically, we used to say ignore everything less than 3 centimeters. Now we say 1 centimeter, but what about all these patients with ultra-short Barrett's or Cardia intestinal metaplasia? What about the biopsy protocol? If the study is incorporating biopsies 1 or 2 per case versus a Seattle protocol every 2 centimeters, you're going to detect Barrett's differently. And finally, depending on who you're looking at, men versus women, etc., the prevalence is going to be different, and the incidence will be different. For the purpose of my talk, I'm going to go into some of these issues, 2 in particular, especially how we define Barrett's, because this has significant impact on determining what the prevalence and incidence is. In America, in the US, in North America, we state that Barrett's should be diagnosed according to the classic principles of endoscopic appearance of columnar mucosa with a biopsy showing intestinal metaplasia. But as you all know, recently in the UK, the British Society of Gastroenterology has come out and said, well, the biopsy showing intestinal metaplasia is not mandatory. If you simply see columnar mucosa endoscopically, that patient can be diagnosed with Barrett's. This is on the assumption that false negative biopsies may exclude patients from undergoing surveillance, and we know that sampling errors are a significant problem. But apart from that, there's also ongoing controversy on whether goblet cells even mean anything in Barrett's esophagus. We all know from historical data that intestinal metaplasia is linked to esophageal adenocarcinoma, but from a biologic standpoint, the goblet cells are unlikely to be the direct source of dysplasia or cancer. These are well-differentiated glands, and the cancers may be occurring elsewhere. So it's often thought now to be a surrogate marker for mucosa at risk, and that at-risk mucosa may simply be cardiac mucosa. So let's look at some of the reports on the incidence of Barrett's from around the world over time and put into context what that means in light of these different definitions of Barrett's. This is a study that came out from the Mayo Clinic looking at residents of Olmsted County over 3 decades, and you can clearly see in this graph here an uptick in the diagnosis of Barrett's esophagus. Now these are all long segment, 3 centimeters or greater, biopsy proven. Now short segment Barrett's was not really recognized until the 80s, and you start to see this uptick here as well. But interestingly, when you plot out the number of endoscopies being done in that population, the authors conclude that this is not a real increase in the incidence of Barrett's, but is in fact coming up in proportion to the number of endoscopies. They actually conclude that they are underdiagnosing Barrett's because they saw a 10-fold increase in esophageal adenocarcinoma, and only one of those patients had an antecedent diagnosis of Barrett's. Here's a study coming from Scotland, again looking at about a decade, and you see here over time the incidence of Barrett's, now controlled for number of endoscopies, has increased significantly. This is 1.4 cases of Barrett's per 1,000, going up to 42.7. Now in this study, they did not mandate intestinal metaplasia to be part of the definition of Barrett's. And if you look at the actual pathologic specimens and then plot out those that were confirmed with goblet cells, the incidence is much lower, but still significantly growing over time. But you could see here it's roughly about 40%. A similar observation was made in the Netherlands. Over time, the incidence of Barrett's esophagus going from 19.8 to 40.5 per 1,000 EGDs. But again, if you look at the histologically confirmed cases, that number drops to about half. It's interesting how that 50% figure seems to be constant through different parts of the world. Here's the incidence of Barrett's esophagus at Temple University over 1 decade. There are 2 lines here. The upper line, again, matched for the number of endoscopies. You could see grows over time. But if you look at the actual histologic confirmed cases with IM or intestinal metaplasia, that number drops significantly, although still increasing with time. So there does seem to be an actual increase in the real incidence of Barrett's, but there's widely different numbers depending on whether you mandate intestinal metaplasia on a biopsy or just rely on endoscopic appearance alone. So if you look at that a little more closely on why there's such a big discrepancy, this study comes to us from the Kansas City VA, and what they did was they took their columnar-lined esophagus patients from a cohort of 1,000 patients being screened, and they break down the columnar-lined segment into ultra-short, short, and long. And you can see that the prevalence of intestinal metaplasia goes up. It increases as the length of the mucosa goes up. So in 90% of patients with a long segment of columnar mucosa, they could prove intestinal metaplasia. But in ultra-short segments, only 1/3 of those patients had intestinal metaplasia. So the yield on the biopsy is much lower as the segment of the Barrett's gets smaller. Overall, 23% of their patients had columnar-lined esophagus, and about half had actual intestinal metaplasia, again 50%. So what happens to these patients who have columnar-lined esophagus without intestinal metaplasia? If you take the premise of the British Society of Gastroenterology, and you follow these patients, they assume that almost all or the majority of these patients are going to have intestinal metaplasia eventually. Well, this study comes from another VA down in Houston, and what they did was they took patients with a columnar-lined esophagus, but biopsy negative on their initial scope, and then they brought them back after 2 years. Most of these patients, 71%, remained negative on biopsies. Only 29% actually had intestinal metaplasia. A similar observation is brought from the Munich group. This is endoscopy positive columnar-lined esophagus, but histology negative. They determined that these are indeterminate cases. They brought these 49 patients back after 2 years, and they found only 11 patients actually had intestinal metaplasia. Part of the problem is short segment or ultra short segment Barrett's esophagus, and that transitions to the second topic of concern, which is Cardia intestinal metaplasia. And should we be including these cases as Barrett's esophagus? There's a lot of unreliability in determining who these patients are. If you look at this representative picture, on the left, these upper and lower pictures are with the stomach insufflated, and on the right, with the stomach deflated or suctioned out. And you can see the challenge, even on narrowband imaging, really determining if they have a 1 centimeter segment of columnar lining rising above the gastric fold. We just have a very poor and unreliable method of determining where the limit of the esophagus ends and where the stomach begins. But it's possible that this is significant because intestinal metaplasia is always abnormal, and microscopically, this is usually indistinguishable from Barrett's esophagus. If you do not tell the pathologist where that biopsy is from, they will usually report it out as Barrett's. Now, we have to exclude gastric intestinal metaplasia from Helicobacter, but in those cases, it does seem to be real. And are CIM cases contributing to this rise in gastroesophageal junction tumors in this green line, which are categorized as Cardia tumors, because these certainly are not coming from Barrett's. Well, we did some molecular studies as well as immunohistochemical studies to show that CIM is actually very similar to Barrett's. In this study, we took CIM biopsies, Barrett's biopsies, and gastric intestinal metaplasia biopsies, and ran a panel of genes on RT-PCR. And then we had our statistician run a analysis to see if we can categorize these specimens based solely on molecular data. And you can see that CIM is often mixed up with Barrett's, and Barrett's is often mixed up with CIM. And rarely does gastric intestinal metaplasia get misclassified just on molecular data. If you combine CIM and Barrett's, it's even more convincing. 95% of the cases are correctly classified. Again, very rare that GIM is misclassified. So we think that biologically, CIM is an extension of Barrett's. It may not have the same risk, but this has to be considered when we look at the prevalence and incidence of Barrett's esophagus. So in conclusion, Barrett's esophagus is not overdiagnosed at this time. We can't say it's overdiagnosed when we continue to see an increased incidence of esophageal adenocarcinoma, most of whom are presenting with disseminated disease at presentation. Barrett's esophagus is really increasing around the world, and if we eliminate the requirement for pathology with just endoscopic criteria, we may essentially double the number of patients with Barrett's esophagus, and then we may really be in a situation of overdiagnosis. And finally, including Cardia intestinal metaplasia will certainly expand the number of Barrett's patients as well, but I think there's more biologic rationale to do this rather than rely solely on endoscopic criteria. Thank you.